Hi, I am Dr. Mangesh Kamath. I am a consultant medical oncologist, hemato-oncologist and bone marrow transplant physician.
I am Dr. Anil Kamath. I am a consultant surgical oncologist.
So today, both Dr. Anil Kamath and myself, we have got together to talk about prostate cancer. So prostate cancer, as not many would know, is a type of cancer which occurs in males who have a gland which is related to sexual reproduction or the nurturing of the sperms, called as the prostate. This cancer is highly prevalent. However, not much is known about prostate cancer. And September is celebrated as the Prostate Cancer Awareness Month. So, Dr. Anil Kamath and myself, we thought of making you all aware about what is prostate cancer and how is prostate cancer managed by oncologists like Dr. Anil and myself. So, Dr. Anil, prostate cancer, is it a common cancer in India, and how often do you encounter prostate cancer in your practice?
Yes, prostate cancer traditionally was thought a disease of the West. In USA, prostate cancer in males always used to be the number one cancer. The traditional thinking was that it's not so common in India, but it is no longer so. We encounter it quite frequently in India also. So I think prostate cancer is something which everybody should be aware of. It's quite common in India too.
As a medical oncologist, I see prostate cancer in two occasions. One is when the definitive therapy, that is either surgical therapy or radiation therapy, is not possible for a prostate cancer which has come in what we call as early stage, but at not such an early stage that easily surgery or radiation can be done. And obviously, in most instances, as a medical oncologist, I see patients when they come in metastatic prostate cancer, that is when the cancer is spread to organs other than the prostate, such as bones or lymph nodes or any other organs in the body. So, typically, when you see prostate cancer patients, what stage do you see them with?
The initial symptoms overlap with those of what we call benign prostatic hyperplasia, which is a very common occurrence. So in these cases, the patients typically present with difficulty in passing urine. If there is blood in the urine, that is something which people should consult a doctor. And normally we see prostate cancer in elderly people. Most of the cancers that we see, patients are 60 and above. Very, very rare to see prostate cancer below that age. The next thing is the symptoms can be related to the spread. So sometimes the way of detecting a prostate cancer is the patient directly comes with some bone problem, extreme bone pain, especially in the back. And later on when we evaluate, we find that he has actually got a prostate cancer. So these are the various ways in which prostate cancer patients present to the doctor.
Prostate cancer, my dear audience, you should know, is a very common cancer. It is not that it is probably one of the least encountered cancers by oncologists. However, prostate cancer many a times can go undetected in the early stages, and sometimes because it is primarily a disease of the elderly, many patients are known to die with prostate cancer than due to prostate cancer. So prostate cancer is not one disease. Many a times certain prostate cancers can basically manifest slowly and gradually over years to even decades, whereas certain subtypes of prostate cancer can basically manifest with symptoms immediately within a matter of few weeks, and patients, if not treated, can even die early. So, Dr. Anil, when you see prostate cancer patients, are they already diagnosed or are they coming to you with symptoms? What exactly happens? How do you see them?
Yes, most of the time as oncologists, we get cases after they are diagnosed. But I want our audience and people to be aware of the symptoms. Every elderly patient, the urinary problems are very frequent. And the more common counterpart of prostate cancer, that is benign prostate, that's a very, very common problem. But what are those symptoms that people need to be aware, which could be this one? Especially blood is one thing. I think if there is blood in urine, that is one thing which you should be aware of. Even otherwise, the hesitancy and when they have symptoms of BPH, at least a basic evaluation for prostate cancer has to be done.
So today, nowadays, we are seeing a lot of our citizens who are going for master health checkups, either they through their companies or they are going voluntarily to undergo master health checkups. So master health checkups helps you in two ways. Basically, because most of the master health checkups will have an ultrasound scan, and many of them nowadays do PSA.
Yeah.
So you can get probably early indications that something is wrong. But remember one thing: not all PSA slight elevations are prostate cancer,
Yes.
and not all prostate enlargements are prostate cancer.
Yeah, that's right. That's right.
So if you do have symptoms, and if your PSA is raised, and maybe even your ultrasound is showing that prostate is enlarged, how do you go about diagnosing a case of prostate cancer?
The first thing for prostate cancer is to meet someone experienced in dealing with these issues. So the doctor, when doing clinical examination with the gloved finger, he does a rectal examination. So this, by this we can feel if there is any hardness, any nodules felt in the prostate, which will require a biopsy. The next step, if there is suspicion, would be to do a biopsy. The biopsy usually is done through the rectum. We call it under ultrasound guidance, what we call TRUS, TRUS guided biopsy. So in this, the radiologist finds areas which are suspicious, and biopsies are taken from these. These biopsies are then sent to the pathologist, who will see and confirm that there is prostate cancer. So this is the way it is diagnosed. Prostate cancer is usually diagnosed by this way.
So, but the interesting part is all this evaluation can be done at OPD basis,
Yes,
isn't it?
yes,
You need
that's
not
right.
actually get admitted or anything like that.
Yes.
It can actually be done at an
OPD basis, yeah.
So remember one thing, many a times I have seen some of the patients who come to me, they would have gone for prostate enlargement and also PSA elevation to a non-oncologist. We don't have anything against them, but it'd be ideal to manage them, because there are certain clear-cut indications that something is wrong, and I would encourage my audience, whosoever have these kind of test reports or these lab reports, to actually go and seek an oncologist who will be able to guide you. Because remember, just like any cancer, prostate cancer also, if it is detected in the earliest stages, is extremely curable.
Yes.
So what kind of cure rates you have seen when prostate cancer are diagnosed early, Dr. Anil?
The prostate cancer, like you described earlier, there is a contrast to this one. Sometimes we get tumors which are so harmless, they outlast the person's lifetime. So not doing anything or active surveillance is also an option for many prostate cancers. So that is on one side we see such that. On the other side we see certain prostate cancers which are very, very aggressive, and within few months or years they don't respond to any treatment, and almost the patient succumbs within few years. But luckily for us, most prostate cancers belong to the first category, which are slow growing, and even in metastatic cases we can expect a very long survival. Unlike most other cancers, we can see that they are treated and they can outlast the disease.
So what are the indicators for you? As a surgeon, you would see a lot of patients who are coming. So what are the indicators that tell you whether this prostate cancer patient is going to have an aggressive course, this patient will not have such an aggressive course, maybe an insidious slow course? What are the indications?
The first is from patient factors. Elderly patients are more likely to have less aggressive cancers. The younger the patient, if a patient of say 50 has a prostate cancer, we are more or less sure that it is going to have a aggressive course. That is the first thing. The next thing, the biopsy itself. The normal adenocarcinoma has got a more benign course, as compared to say something like a round cell tumor or some non-adenocarcinoma histologies. That is the second point. And those which have got only bone disease, they are likely to be less aggressive as compared to those which have spread to other this thing like the lungs or liver or even the lymph nodes. These tend to have. So these are some of the points which tell us which cancers are aggressive and which are not so.
Yeah, from my perspective, there are similar points. So basically, we look at the grade of the tumor. Basically, when we do a transrectal ultrasound guided biopsy or any biopsy of the prostate, we tend to get the grade and we divide it into certain grades. We classically call them as Gleason's grade. And based on this, we get a feeling that this patient is going to have an aggressive course or not. Number two, if the patient presents to us with a slow growing tumor at an initial phase, most likely these patients are going to do well because they are, they have come to us at an early stage, so we can offer them curative therapy. And last but not the least, the type of metastasis, as Dr. Anil told, that where it has spread. Has it spread to the bone or it's outside? Remember one thing, my dear audience, that all prostate cancer are not the same. Remember that again. And number two is, prostate cancer is caused by repeated or a prolonged exposure of our body's testosterone. The prostate, when it's exposed to testosterone for a long time, that's when the prostate cancer genesis occurs. So there are some cases where the prostate cancer, if it occurs in extreme elderly and it is detected in early stages, we usually consider it to be slow growing, as opposed to somebody who is much younger and develops a fast growing prostate tumor. So once we have a prostate tumor that is diagnosed, we usually do the staging. So yes, we call stage 1, stage 2, stage 3, stage 4. But is only staging important? Do we look at other factors while we are going for treatment?
Yes, luckily in prostate cancer we have a lot of options nowadays. So broadly, for treatment purposes, any prostate cancer would be classified as either early, locally advanced or metastatic. So in each of these cases there are treatment options. When it comes to early prostate cancer, or prostate cancer which is confined to the prostate, not spread to the lymph nodes, not spread to anywhere else, here the options would be between surgery and radiation. And in, say, elderly patient, even wait and watch is an option if he has got a very low this thing. But a younger patient who has got a life expectancy much more than 10 or 20 years, we do tend to offer treatment rather than wait and watch. When it comes to surgery and radiotherapy, there has always been a contest as to which is superior and which gives better results. Surgery nowadays, most of the time it is performed robotically. It is what is called a robotic radical prostatectomy, where the entire prostate is removed. So this is a fairly major surgery, but it has got good results when you perform it in the appropriate setting. Similarly, radiation also has good results. In radiation, the rays or this one are delivered through a machine to the target area, and once the external radiation is completed, internal radiation is given using beads or wires. So there has always been a contest as to which is superior. Both have their pros and cons. Basically, the decision is done in consultation with the patient. There are certain factors which we take into consideration. One is the comorbidities. If he has got very severe comorbidities, he may not be a very good candidate for surgery. Second, the desire for sexual function, that also plays an important role, which is somewhat better with surgery as compared to radiation. And the acceptability of the patient to various complications and all. These are something which options are there, and the options have to be exercised depending on the preferences of the patient. Yeah. Now about locally advanced, maybe you can just elaborate a few points.
So basically, like Dr. Anil basically mentioned, that prostate cancer requires a multidisciplinary discussion. So when a diagnosis of prostate cancer occurs, the best way of treating prostate cancer is by an elaborate baseline discussion between a surgical oncologist, medical oncologist and a radiation oncologist. The reason why we mentioned is, every patient is different. For example, a 60-year-old patient with multiple comorbidities, already having a lot of issues, a lot of heart problems and all that stuff, in those patients, my treatment plan through the multidisciplinary board will be much different than the same aged patient who has no comorbidities, is able to even probably run marathons and all that. So our tailoring of the therapies becomes very important. In fact, many a times, I can even speak for Dr. Anil on this, that we probably even recommend just active surveillance or watchful waiting for some patients. We don't even offer them therapy, saying that you probably don't require any treatment right now, and we will only offer you treatment when probably the tumor is advancing or increasing rapidly. So that is one thing that is very important to us. We always look at what is called as an expected life expectancy of the patient. Basically, expected life expectancy means that there are certain calculators available by which, through all the profile of the patient, that is the patient's general condition, comorbidities and all those factors, we look at how long this patient is expected to survive. For example, if I see a patient at the age of 70 coming to me with prostate cancer, if the life expectancy of this patient is going to be more than 10 years, based on his current general condition, I would be more inclined to treat the patient, because based on this I would be able to probably conserve that expected life expectancy. On the other hand, if I have a 70-year-old patient who has really severe comorbidities, has lot of effects due to diabetes, heart issues and all that, and if the life expectancy is 3 or 4 years, by not treating the prostate cancer, I would be doing more service to this patient, because the prostate cancer itself will not kill the patient, and the patient can live with the prostate cancer for beyond 3 or 4 years. That is very important. But the challenge comes, as Dr. Anil said, is when there is something called as a locally advanced prostate cancer. That means the tumor has gone outside the prostate, is now starting to involve the nearby structures. Now that is very critical, because the involvement of the nearby structures can give rise to a lot of complications and a lot of symptoms for the patient, due to which the patient cannot live a asymptomatic or a quality life. At this circumstance, we are forced to make a decision so that we can either reduce the extent of the prostate tumor, or reduce the prostate tumor and then probably offer radiation or surgery, as the case may be. So in this case, what do we offer to the patient? Is it chemotherapy? No, we don't offer chemotherapy. We give what is called as androgen deprivation therapy, or ADT it is called, wherein we are giving medications to the patient which are going to reduce the testosterone levels. And as I told you a little while back, testosterone is known to drive the prostate tumors. So when I reduce the testosterone level, the prostate tumor, which is devoid of the testosterone exposure, shrinks. And that is the beauty of treatment of prostate cancer, is that you do not have to employ chemotherapy in a large instance, a large number of cases, and your hormonal therapy itself will work like magic. And once we give this androgen deprivation therapy and the tumor shrinks, then we can offer either surgery or radiation. So after giving androgen deprivation therapy, what are the things you assess, and when you think radiation should be offered, or when you think surgery should be done?
Yeah, in locally advanced cases, once androgen deprivation therapy is, the prostate shrinks. Now, traditionally the thinking was that these patients are not suitable for surgery and they have to go for radiation, because but nowadays there is a concept coming that there is a planned combination of treatment, that the patient undergoes surgery and later radiation also. The survival with this has been found to be superior to that of this thing. The way that we assess response is one, PSA, which is a simple blood test. PSA coming down itself would be an indicator that the treatment is working. And next, imaging, as and when required. We do for local information, we do a MRI. And if we want to assess spread, we do a PSMA PET scan. So these two tests are utilized to assess the response. So that's how locally advanced treatment works. A combination of first androgen deprivation therapy followed by local therapy, which is either surgery or radiation or both.
So that brings me to the debate. There is a lot of debate now, when to give radiation, when to give surgery, or what is better, radiation or surgery. Can you just throw a little light on what are the advantages of surgery or radiation, and what are the advantages of radiation or surgery?
Yeah.
What instances you would pick them?
So the debate is more in terms of early prostate cancer. So in early prostate cancer, there has been an innumerable amount of debate as to which is superior. There is nothing superior. We have to just discuss with the patient what his preferences are. Basically, if it is a one-shot treatment, that the patient doesn't want a prolonged 6 weeks, 8 weeks treatment, he wants something to get over within 4 days, 5 days, surgery would be the treatment of choice. Very important aspect to be considered. The nerve preservation is very important. And what happens during surgery now, with the advancement of surgery, with the magnified view available through robotic surgery and all, nerve preservation has become much more easier. Nerve preservation means better sexual function. For those patients in whom this is important, surgery is superior to radiation. Whereas surgery carries some amount of anesthetic risks, some amount of complications related to leaks and incontinence. Patients who are very much worried about these complications, radiation would be the treatment of choice. Younger patients who have got very good survival, the normal tendency is to choose surgery over radiation, especially if there is not so aggressive tumor.
So then there is this question of, is robotics better, or is laparoscopic better, or is it open? What is your take on this? Because a lot of patients believe that robotic is the best, or laparoscopic is best, and I have heard different people talking about different types of surgeries. As a really senior surgical oncologist with years of experience, what are your thoughts on this aspect?
See, these are all finally modalities. The person doing the job is far more important than these technologies. All are good enough, but in terms of technology, if I have to choose, I would say robotic surgery is something which is extremely suitable for prostate surgery is extremely suitable for robotic type of this thing. The reason being, robotic gives us the necessary magnification which will help us to preserve the nerves, and the location of the prostate is deep down in the pelvis. The rigid instruments of laparoscopy make it difficult to do a precise suturing. So this can be overcome by robotic surgery, which have got flexible arms. So if the technology is to be chosen for surgical treatment of prostate cancer, if there is one thing that we should choose, it is probably robotic surgery. It does offer certain benefits which outweigh that offered by laparoscopy and open surgery.
So now that we have understood about how it is managed by the surgeons or the radiation oncologists for early stages and locally advanced, so let me throw some light on how, as a medical oncologist, I would manage locally advanced prostate cancer and also metastatic prostate cancer. So again, like I said, locally advanced prostate cancer sometimes becomes very, it can vary from each oncology team to another. But by and large, usually as a medical oncologist, I would come into the picture because immediately surgery or radiation may not be possible, and even if it's possible, may be associated with some complications that could occur because of the vast resection or the vast radiation field that has to be offered to the patient. So the role that we would play is we usually shrink the tumor as much as possible. There is no particular way as to predict how much it will shrink, but usually I have seen that over a matter of 2 months to 4 months, the tumor tends to shrink significantly, and once it shrinks significantly, then I would refer it to my surgical or the radiation oncology colleagues, who would then provide the best form of treatment so that we can attempt to cure prostate cancer. Now, unfortunately, in my experience and the experience of many oncologists, prostate cancer patients coming with stage 4 disease or metastatic disease are far too common. I would probably say that more than 50% of prostate cancer patients in our country probably come to us after the prostate cancer has spread to either the bones or lymph nodes or some other organs. Now, is stage 4 prostate cancer something to be extremely disappointed about? Of course, whenever cancer has spread to another organ, it is disappointing because cure is usually not imminent. However, it is not something that I would give up on. As all oncologists, including surgical oncologists, radiation and medical oncologists agree today, stage 4 of any cancer is not something that we would give up on immediately. Maybe 2 or 3 decades ago, stage 4 cancer would mean that we would give up and ask the patient to basically get symptomatic relief. But prostate cancer is not one of them at all. In fact, many of us have prostate cancer patients who have lived beyond a decade also. Yeah. Many of them live beyond 5 years as well. Only a handful of patients, probably I would say 15 to 20% of the prostate cancer patients would not live to see beyond 2 years. So it is something that can be managed. However, like every cancer, the first treatment that you're giving to prostate cancer should be the best and the most standardized, because sometimes after you give the first treatment and if it doesn't work on the prostate cancer, the second treatment are usually not effective. So, is there a role for surgery in metastatic prostate cancer?
Yes, most definitely yes. So, as you said, the main treatment in metastatic cancer would be hormone deprivation. There are many ways in which this hormone deprivation can be done. The traditional way is by castration or removal of the testis. The testis being the most important source of the testosterone, which provides fodder for the prostate cancer to grow. So, by removal of both the testes, you are essentially depriving the prostate of this testosterone which is required for them to grow. So the advantage of surgical treatment, of course, surgery is not the only way of androgen deprivation. You can even go for injections, but the advantage of surgery is that it is a single shot. It happens at one, need not be repeated, and the effects are almost definite and immediate. So that is the advantage of surgery. Of course, certain patients may have reservations about losing of the testis. For those patients, there are other options like injections, which are given. These need to be repeated once in 3 months or once in 6 months. But from a cost effectiveness point of view and immediate result point of view, surgery scores over these.
So as a medical oncologist, I do tell my patients that if you want to avoid recurring expenses on the androgen deprivation therapy, these injections usually cost in the range of 10 to 20,000. So I would probably prefer these patients to undergo an orchidectomy and one-time procedure, maybe even 1 day of admission
Yes.
or maximum, and then with that the prostate can be deprived of testosterone, because as we would know that the maximum production of testosterone occurs in our testes, and once you remove both of the testes by the surgery called orchidectomy, you can probably remove the fuel for the prostate cancer. If that is not acceptable, then androgen deprivation care therapy can be given. Some clinicians even offer radiation to the testis and to destroy the testis tissue, and these are the ways. So basically, whenever we get a patient with metastatic prostate cancer or prostate cancer that is spread to other organs, we believe that the primary fuel for the prostate cancer is the testosterone. So it becomes very important for us to make sure that the testosterone is removed, because at this particular time this prostate cancer is called as a hormone sensitive prostate cancer or castrate sensitive prostate cancer. With this, once you remove that, there are sometimes you have seen amazing responses wherein the prostate tumor as well as the secondary deposits come down by more than 70 to 80% also. And there have been few instances where I have seen literally the entire disease has vanished as per the PSMA PET CT scan. But unfortunately for us, even after this, there are ways that the tumor finds itself to actually replicate and grow or progress again. This phase is called as the castration resistant or the hormone refractory prostate cancer. What happens in this situation is the prostate cancer is deprived of the hormone or the testosterone, but it is a cancer. Remember, cancer is a tissue which can grow autonomously. So the cancer cells find a way wherein they rely on something other than the testosterone to fuel the tumor and drive the tumor. Sometimes they undergo spontaneous mutations or spontaneous changes inside the DNA, or they start producing the hormone or certain hormone related substance by itself, due to which the prostate tumor starts driving up. Now in these cases, even after you are given you are done an orchidectomy, or even you are giving injections to deprive the testosterone, the prostate cancer starts growing. Now how do you know that it's growing? Is initially we do a PSA levels or the prostate specific antigen levels, and if that is growing, we confirm it with a PET CT scan or a PSMA PET CT scan as you call it, and after we confirm this, we have to treat these patients. So what are the options for us to treat these patients is, again, we call certain molecules which are called as hormone modulator therapy. There are certain molecules which are available which modulate the action of the hormones in the prostate cancer cells, or otherwise we rely on chemotherapy. So in prostate cancer tumors, we rely on chemotherapy only when we have exhausted the hormone sensitive therapy, or in certain cases when I told you that prostate cancers can be aggressive. In those cases, chemotherapy can be offered upfront as well. There is some evidence or some data that is coming up saying that when the prostate cancer is detected in the metastatic stage, or if it is spread, it is possible that you can give radiation therapy to the local area as well if you are extremely symptomatic for that, by which not only you can get relieved of your symptoms related to urination, but also it is known that it could probably help in control of the disease which has spread outside as well. So this is about management of prostate cancer. So are there any ways that patients can detect prostate cancer in the earliest stage? Any screening methods that are available as per your knowledge?
Elderly patients, the basic screening is a PSA. So I would suggest anybody who has crossed say 60, 70 years should have a baseline PSA, which is most often done in all these corporate health checks. So baseline PSA will help us this time. The PSA is the basic level test. No other test is required. As and when required, the imaging should be used. If the PSA is high, then we can go for the other tests.
Yes, so it is possible because PSA is a test which is done by many labs today, and sometimes maybe an ultrasound can also be done if you want to know. And as soon as you see that these reports are not normal, both of them, you could probably visit an oncologist who will probably do a test and rule out cancer for you. But remember, all prostate enlargements are not cancer. There is a very common condition called as BPH, or benign prostatic hypertrophy. This is more common a condition than cancer, and this can be very, very easily managed with certain tablets, again, which work on the prostate cells, and even in those cases the swelling of the prostate can be reduced to a far extent. So there is a question that many patients ask, especially when their parents have prostate cancer. How do we prevent? How can I prevent prostate cancer? Has anybody asked you this question?
Yeah, but like most of the cancers, it can be detected early, but I don't think there are definite ways of preventing it.
Yeah. So there is a lot of debate on what are the things to do. You would have heard that this food substance is going to prevent cancer, this food substance. But generally what is told is when it comes to prostate cancer, if you have had a very frequent sexual activity in your youth, or even in your middle age and beyond, it is known that your risk of getting prostate cancer is reduced to a large extent. So frequent sexual activity is one way to reduce your chances of developing prostate cancer. There is data that if your diet is good in vitamin E, then in those cases also your prostate cancer can be reduced to a far extent. There are a lot of things about these trace elements called as selenium. So even if your diet is rich in selenium, it is also known to reduce the risk of prostate cancer. And by and large, prevention is possible, but more important is to undergo screening, because screening is one way wherein you can definitely detect prostate cancer at the earliest stage. And there are robust treatment modalities that are available, whether it is in medical oncology, surgical oncology, or radiation oncology, by which truly prostate cancer is one cancer we really look at treating patients well. Cure rates are quite good, and even if they are not curable, control rates are extremely good, so that we can manage prostate cancer efficiently. So are all the facilities available when it comes to management of prostate cancer in Bangalore or in India?
Yes, I think Bangalore is very well equipped for these. We have very robotic facilities available for surgery in many of the centers. Radiation, also advanced radiation like IGRT, IMRT, they are available, I think, in many centers in Bangalore, much better than even Delhi, Mumbai and other this one. And I think it can be effectively treated. Many centers have these facilities.
A frequent question that has been asked to me, especially by a few patients' children, is there a chance for me to get prostate cancer? Yes, there is a possibility of getting prostate cancer, and this is possible if your parent is harboring certain genes that are transmissible to their children. So inheritable prostate cancers are common. There is a gene called BRCA or BRCA, and there are certain other relatable genes to BRCA which are responsible for prostate cancer. And yes, if there is a family history of prostate cancer or breast cancer in your family, ovarian cancer in your family, then it is possible by genetic counseling, which all of us do for our patients. And there are also certified genetic counselors as well, who would be able to determine your risk of developing prostate cancer in future. And by efficient testing, we can probably detect these genes in your body by a simple saliva test or even a blood test. and once it is detected, we can offer you certain methods to either prevent prostate cancer or probably detect prostate cancer at the earliest phase. Friends, I hope we have given you all the information about prostate cancer. So how prostate cancer is diagnosed, what are the symptoms related to prostate cancer, and if it is diagnosed, how should it be managed. Ideally, it should be managed in a cancer center where all the experts are available for treatment. Then staging is very important. We need to stage prostate cancer, and as Dr. Anil said, the right scans have to be done. If it is a local disease, then you should do a MRI scan. If it's spread elsewhere, then probably a whole body PET CT or a whole body CT scan is much more convenient and useful for us. Then how do you manage each stage of prostate cancer? Are all prostate cancer treated the same way? Are there intricacies to management of prostate cancer? And if it is metastatic prostate cancer, you should not give up. In many instances, prostate cancer patients with disease spread to other organs have survived for more than 5 to 10 years, and the best therapies are available today. Not all treatment for prostate cancer is done by chemotherapy. Hormonal therapy is commonly employed by medical oncologists like myself. We rely on primarily hormonal therapy or hormonal modulating therapy, I'd like to call it, and prevent the progression of prostate cancer. How to prevent prostate cancer and how to screen prostate cancer. So we have basically covered almost all the topics. I hope this concise discussion between Dr. Anil Kamath and myself has helped you not only understand about prostate cancer, but also to get questions about prostate cancer. In case you have any queries, you can visit our website www.helioscancerhematology.com. Our website also has phone numbers by which you can also get on teleconsultation or video consultation with our team of oncologists. We definitely will be able to answer all your queries with regards to prostate cancers or any other cancers and hematological problems. So make sure you visit our website. This video will be available there as well, and any other questions that you have, you can ask us. So thank you very much for your patient hearing. Thank you, Dr. Anil, for your insightful thoughts. Make sure that prostate cancer is diagnosed as early as possible.
Thank you.